Hi, everybody. As people are joining, I just want to make some introductions. My name is Dana Howard. I am a member of the Center for Bioethics and the Philosophy Department at The Ohio State University. I'm an assistant professor there, and welcome to our monthly care panel, which is sponsored by the Center for Ethics and Human Values. The CARE program generally aims to support Ohio State's Chair of Values mission in the domain of research by building community around discussions of research integrity. And it's presented with support from the OSUMC Center for Bioethics, as well as the Clinical and Translational Science Institute. And we are so happy to have all of you here today, as well as our panelists. So today we're going to be talking about a really interesting and in some ways novel aspect of research, the ethics of researching psychedelics. The study of psychedelics as a therapeutic tool raises some profound ethical questions about medicine, society, and patient care. And this panel will bring together our experts to talk about just sort of thinking about how historical stigma related to these kinds of interventions affect how we think about researching it. How should we understand current public perceptions related to evaluating its medical applications and its use? And how should we think about informed consent and protecting potentially vulnerable participants when it comes to this research? And I'm delighted to have Doctors Andrew Peterson, Subhdeep Virk, and Stacey Armstrong as our panelists. Um, Andrew Peterson is an assistant professor in the Department of Philosophy at George Mason University, and he is written extensively about the ethical issues of psychedelic clinical care and research, and also has a broad background in neuroethics. And we also have, as our OSU panelists, Dr. Stacey Armstrong, who's a senior researcher and associate director of the Center for Psychedelic Drug Resistance Program. Psychedelic Drug Research and Education Program at Ohio State University, as well as Subhdeep Virk, who is the clinical associate professor of psychiatry and behavioral health at OSUMC, is also the director of the treatment-resistant depression program at Ohio State, and is a principal investigator of a clinical trial using psilocybin as a potential option for treatment-resistant depression. Thank you so much for coming here and sharing your wisdom and your sort of practical experience. We are going to get started with Dr. Peterson. Andrew's going to give a sort of ethical overview of some of the ways that you've been thinking about it, and then we'll go to Subhdeep and to Stacey to present your own sort of experience and ethical sort of aspects of your work. And then we'll start with some questions that I came up with the group. And then we'll take it to Q&A from the audience. So if you are seeing at the bottom of your screen, all of those that are in the audience, there should be a Q&A function. Feel free to ask questions throughout the presentation or throughout the discussion. We'll have plenty of time to ask your questions as well. All right, so to no further ado, thank you so much, Andrew, for joining us. You could start us off.
Sweet. Thank you so much for having me, and I'm feel humbled being surrounded by such smart people. Let me see if I can say something smart as well, and I won't take up too much time so that we can have lots of time for discussion as well. Let's see. Okay. And let me just confirm with the others that are on the panel that you're seeing my slides as opposed to seeing my notes. Is that right? Okay, cool. All right, thanks so much for having me. Today, what I want to do is briefly describe my journey into the world of psychedelic medicine. My journey is by no means straightforward, so I hope that it'll spark some ideas for some of you that we can discuss. I also want to highlight some specific ideas about psychedelics and suffering. Psychedelic therapy is being proposed for a variety of mental health conditions that we'll hear about a bit later. Um, and those mental health conditions are sometimes characterized by suffering. But what kind of suffering is this? And how should we evaluate whether psychedelics are actually alleviating that suffering? These ideas were inspired by a project I worked with my colleagues at Penn Bioethics, and I'm knitting together a variety of different ideas here, so hopefully the presentation isn't too meandering. Okay, now full disclosure, and I'm curious to see what other people, what other folks on the panel, their background is. I'm a psychedelics virgin. I haven't taken psilocybin, I haven't taken LSD, MDMA, or any other psychedelic substance. And so I'm curious about your feedback given my lack of firsthand experience. And interestingly, there's a philosophical question that's sort of embedded here, an ethical question as well. Does expertise in this subject require participation? Or more specifically, should psychedelic practitioners be required to have a psychedelic experience prior to offering this service to patients, which is a huge ethical issue that we've struggled with in the literature. Okay, enough with this preamble. Let's get down to business. My introduction to the world of psychedelic medicines starts through the door of brain injury. So let me tell you a story about brain injury. The story is about a young graduate from the University of Western Ontario, University of Windsor, whose promising career in robotics was cut short in a horrific car accident just 5 days before Christmas in 1999. This is Scott. Scott visited our lab at the University of Western Ontario where I did my PhD, and I got to know his family quite well. Scott suffered a catastrophic brain injury in his accident. When admitted to the hospital, Scott's eyes were open, but he showed no evidence of awareness of himself or his environment. After several months in the hospital and stabilization, Scott was eventually discharged into the care of his family, but he never regained consciousness in that ensuing time. And he was eventually diagnosed in being what's called a vegetative state, a state of wakefulness without awareness. Scott would display semi-regular sleep-wake patterns, but no concomitant evidence of awareness of auditory, visual, tactile stimuli, no capacity to follow commands like Scott, raise your arm to command, and no verbal communication, no responses to yes, no communication. Now, Scott's condition differed from another kind of condition that we sometimes see in these patients called the minimally conscious state. Minimally conscious state patients also display semi-regular sleep-wake patterns, but unlike Scott, they also display minimal yet reproducible behavioral evidence of awareness of themselves or their environment. So they'll raise their arm to command every once in a while, give a thumbs up, or they'll respond to yes, no questions if you ask them. Now, all of you are probably thinking now, like, I thought this was a panel about psychedelics. Why on earth are we talking about brain injury? What gives? Right? Well, I've spent the majority of my career developing frameworks for the ethical treatment of patients like Scott in both research and clinical settings. These patients and their families are the most vulnerable of vulnerable patients. Families are desperate for cures, and they're often willing to go to great lengths to bring their loved ones back from this abyss. So, as you might imagine, I was floored to read in 2019 that a reputable lab at Imperial College London had proposed to give psilocybin to patients in the vegetative state to see if they could wake them up, to hasten their recovery. Now, as you can see from my tweet on the left, this is when everybody was still using Twitter, right? When it was still called Twitter. I was at a genuine loss for words. I was tagging all of my experts in the disorders of consciousness world to say, what gives, right? When I first learned about this, give magic mushrooms to the most vulnerable brain injured patients. What on earth are these folks thinking? That, of course, got me thinking about the science underneath this and why on earth people would think that it would be a good idea to give psilocybin or titrate psilocybin to patients in the vegetative state. Now, the research proposal was so provocative that it was picked up by Vice News. Vice News seems to be somewhat of a litmus test for thinking about psychedelics and if it's sort of breaching the conscience of popular culture. In that interview in Vice magazine, Greg Scott, one of the co-authors of the article, is quoted as saying, "If people say you can't ethically do anything, that we should leave them alone, that produces a neglected group who no one is really thinking about how we can help. When you look at it from that point of view, it's a fairly dreadful situation, just in a different way." Now, we haven't yet arrived at discussing the ethical issues associated with psychedelics, but you may be able to imagine some of the worries that might come to mind for any reasonable person, not least the possibility of something going wrong during psychedelic administration to a person with catastrophic brain injury like Scott. Incidentally, this research team just this month, so this is a long saga of us going back and forth with this group. And in fact, there was a study proposal that came through a small foundation that I review for that was to do just this. And it got funded. And incidentally, the research team just this month published a case report in which they administered psilocybin to a patient in the minimally conscious state. Their findings showed that psilocybin administration did not improve the patient's clinical diagnosis, but they did observe new spontaneous behaviors, including the patient's mouth and eyes being wide open while being in the psychedelic state, and increased functional connectivity of intrinsic brain networks. So during discussion, I'm happy to get into the weeds of the experimental design, but I'll just leave that nugget for all of you here just to contemplate as we go through this discussion. Now, it's not just in the world of brain injury that psychedelic research has caught my attention. A second instance of my interaction with the evolving world of psychedelic research was recent publicity around something called the Eastland Alzheimer's Disease Kit, which was advertised by the biomedical startup Eastland Bioscience. The term Eastland here is a reference to the indigenous community that Carlos Castaneda supposedly visited, as described in his book, Journey to Eastland. Now, in late 2021, Eastland Biosciences applied for a provisional patent to the US Patent and Trademark Office for an at-home psilocybin kit for persons living with dementia. And the press release is the kicker. In the press release, Eastland's chief financial officer and head scientist enthusiastically touted the kit as benefiting not only those with Alzheimer's disease, but also those with, quote, dementia syndromes, stroke, multiple sclerosis, and traumatic brain injury. Let's add them all in, right? As long as we're just listing them off. Now, importantly, there's no current evidence that psilocybin interacts with the mechanisms of these conditions, nor is there robust evidence that psilocybin can allay the mental health issues, such as depression or anxiety secondary to dementia. And so it's unclear that Eastland Biosciences, what the Eastland Biosciences representative had in mind when touting this new product. So, having learned about these developments, my colleagues and I wrote about them in these and other essays. On the right, you'll see our response to the proposal to give psilocybin to persons with severe brain injury, and on the left, you'll see our guidance regarding the use of psychedelics in persons living with Alzheimer's disease and related dementias. These are just two projects that sit in a larger research program run by my very, very smart colleagues at Baylor College of Medicine and Harvard. And that research program aims to build an ethical and regulatory framework for the growing field of psychedelic medicine. One of the milestones of this research program was a workshop at the Banbury Center in Cold Springs Harbor Laboratory. There, we developed a consensus statement on the ethical issues associated with psychedelic science. As you can imagine, many were enumerated, but we had to narrow it down on just a couple. These include respect and reparations for indigenous communities from which psychedelic medicine has evolved, issues related to consent, as we'll talk about in this panel, limitations placed on so-called therapeutic touch, which has been in the media about practitioners touching their clients while they're under a psychedelic state. The potential requirements for practitioners to have used psychedelics themselves, and some other issues. Now, importantly, none of these projects were written to be antagonistic to psychedelic research. I, for one, am super fascinated by it and want it to work. On the contrary, many of us who work with vulnerable clinical populations are thrilled to find new and potentially effective interventions for otherwise incurable neurological conditions or psychiatric conditions. But the worry, as scientists, ethicists, and regulators, what I think we're going to talk about today, is to make sure that the hype of psychedelics doesn't outpace the evidence, right? And so each project provides researchers guidance for how to move forward toward this goal in an evidence-based way. Now, in the brief time I have left, I realize there's a black screen here. Let me just shift gears. I want to outline one of the issues that I found particularly interesting in psychedelic research, the problem of suffering and how psychedelics are intended to alleviate that. And I think that that's going to fit hand in glove with Dr. Virk's work and Dr. Armstrong's work, where they're looking at how to apply psychedelics to psychiatric populations. These ideas have been percolating since writing about the proposed use of psychedelics in persons with Alzheimer's disease. The research for using psychedelics in this population is complex. There is some evidence to suggest that psychedelics, particularly their anti-inflammatory properties, might interact with the mechanism of disease, but these data are few and far between. So it remains to be seen whether that line of research will be fruitful. A far more promising approach is the use of psychedelics to attenuate the psychiatric symptoms that accompany an Alzheimer's disease diagnosis, a diagnosis that arguably can rock people to the core. Let me illustrate this a bit with some examples. So when James Watson, one of the discoverers of modern genetics, published his own genome sequence online, he famously kept secret the region encoding his APOE gene, which is a gene that's well associated with late onset Alzheimer's disease. In 2009, psychologist Steven Pinker, following James Watson, detailed the same process in the New York Times, the experience of learning his own genome sequence. And notably, he also chose not to learn his APOE genotype. Pinker explained, all of us already live with the knowledge that we have the fatal genetic condition called mortality. But my current burden of existential dread is just about right. Now, the presence of APOE speaks imperfectly to one's risk of developing mild cognitive impairment or dementia caused by Alzheimer's disease later in life, yet this gene stirred existential dread in Pinker and perhaps Watson. Why? Well, Alzheimer's disease eventually leads to death, which is itself a source of dread. Yet afflicted patients and families also often worry about this death before death, wherein the mind is lost, but the body persists, right? So our cultural representations reinforce this as well. Persons living with Alzheimer's disease and related dementias experience progressive impairments in communication, in reasoning, and memory, and they also experience a gradual but relentless erosion of the self. For Dan Gibbs, a neurologist who has written about his own experience living with mild cognitive impairment caused by Alzheimer's disease, an early stage of loss of cognitive abilities, the disease for him insinuated itself in the most quotidian of ways. 2 incidents of absent-mindedness, he wrote, in a single day disturbed me. Both were glitches in ordinary kitchen routines I'd done a million times. I always make the salad for dinner. That night, I peeled the cucumber into the salad bowl instead of into the compost container next to the salad bowl. I didn't notice until my spouse asked quizzically where the cucumber peel, why it was in the salad. And then while I was unloading the dishwasher, I put a coffee mug on the shelf where the beer mugs go. Not a big deal, but I've never done that before. And again, I didn't recognize that until I had until my spouse had pointed it out. Now, Watson, Pinker's, and Gibbs' reflections strike me as circling around some similar kind of unpleasant experience. I think that this is a kind of dread suffering, according to which each individual experienced a kind of unpleasantness associated with the anticipation of Alzheimer's disease rather than the experience of Alzheimer's disease itself. This seems related to at least three factors. First, Alzheimer's disease researchers often say that it's a disease of autonomy. And in Western cultures, we really value autonomy. So the loss of autonomy can seem pretty scary. Second, in the early stages of the disease, an individual who's diagnosed with this condition bears witness to the loss of their own mind. As Gibbs describes, you become hypervigilant of your own thoughts. You want to make sure that they're all in order so that they don't slip away until you have these glitches, and then you completely are unaware of these glitches occurring at all. And third, Alzheimer's disease has an awful reputation in society. It's regarded as a death in slow motion or as a social death in which a person dies before the body dies. Persons with AD diagnosis will therefore often self-stigmatize. So given these considerations, it's only reasonable that people who receive such a diagnosis prior to the onset of clinical symptoms, or at least very early in the disease, are likely to experience some kind of dread. And so it's no surprise that research programs are exploring novel interventions to address depression, perhaps dread, in individuals with early onset AD. Recent psychedelics trials have shown promising results for a variety of psychiatric conditions, including treatment-resistant depression, PTSD, and trauma from domestic abuse, which we'll hear about a bit later from Dr. Virk and Dr. Armstrong. And it thus stands to reason that psychedelics might help people with a diagnosis of Alzheimer's disease make that transition to a new way of life. So here you'll see the homepage for a psilocybin trial that's being run at Johns Hopkins Center for Psychedelic and Consciousness Research. If you go on clinicaltrials.gov, you can see their proposed study design. The research group is enrolling 20 participants with mild cognitive impairment or early onset AD and clinically significant symptoms of depression. The intervention is an 8-week course of study treatment, including 2 psilocybin sessions with follow-up assessment of up to 6 months after the final psilocybin session. The study will then assess quality of life in participants from pre to post-treatment measures. They're going to use the Cornell scale for depression and dementia and the quality of life Alzheimer's disease scale. And most studies, and I'm curious to hear what Dr. Virk and Dr. Armstrong is doing, but through my own arm's length research of study designs, many psychedelic-assisted psychotherapy studies are designed this way. Participants receive a treatment ensemble of psychedelic substance with guided psychotherapy in a controlled setting, and then the outcome measures look at changes in psychiatric symptoms, most notably depression, quality of life, potentially anxiety. The puzzle, however, this is where the philosophical brain goes off of me. The puzzle is that these outcome measures might not address the kind of suffering that psychedelics are intended to alleviate. Psychedelics don't just address depressive symptoms, they can, but they don't just do that. They reorient your entire life outlook. They address a crisis in meaning, not just psychiatric symptoms. And so it might be necessary to develop an alternative outcome measure to evaluate psychedelics are effective in addressing the dread suffering associated with some terminal diagnoses. In research with my colleagues at Penn, we came across preliminary work on this existential concerns questionnaire. And in this questionnaire, there are items for I get anxious because of losing touch with myself. I worry about having to let go of everything at the moment of my death, and I'm afraid that I will never know myself at the deepest level. It may be that an instrument like this might be more appropriate for assessing the benefit accrued by psychedelics in addressing existential suffering that's associated with a terminal diagnosis or some psychiatric conditions. Okay, with that, I'm going to shut my mouth now. I'll pass the mic over. Thank you, everyone, for your attention. I hope I've left enough breadcrumbs for discussion, and I look forward to your feedback.
Thank you so much, Andrew. There's already questions in the Q&A, so I just encourage participants in the audience to continue asking questions there, and we're going to get to them. And before we do that, why don't we start with Subhdeep? You could start and introduce yourself, your work, and some of the ethical issues that have come up as you're doing this important research.
Sure. I'm Subhdeep Virk. I'm an associate professor of clinical psychiatry in the Department of Psychiatry and Behavioral Health at Ohio State University. I lead the treatment-resistant depression and interventional treatments for advanced depression here at Ohio State, and I've been involved in research with psychedelics for about a couple of years now. I did start with use of ketamine in treatment-resistant depression, and now is ketamine, which has been approved by FDA for the as an augmentation treatment for depression and suicidal ideation in context of depression. And then currently, I'm doing the sponsored trial for use of psilocybin. It's a phase 3 trial looking at safety and efficacy of psilocybin for the treatment of depression. Hearing Andrew present a lot of challenges, to begin with, starting from how do you select the appropriate patients, and how can this treatment be helpful in spite of all the burden that it carries. And it is not new. Psychedelics are not new to us. They're it's a comeback of something that has been there for decades and, took a break and then is now coming back. And the question is, why? Why is psychedelic being studied? Why are we all excited about this treatment, and why is there a lot of hype? And I might be preaching to the choir over here when I say that, if I take depression, and I know we heard about neurological conditions, and I have to say I have limited experience of my use of psychedelics in that area, but I can, share my experience with use in psychiatric issues, especially or illness, especially depression. And so depression, as we know, people like we talked about suffering. And so whether that's a neurological condition or a psychiatric condition, we're looking at people who are struggling and suffering for a long period of time, because these are chronic illnesses. And when you hear about, the data for treatment in just major depressive disorder, I'm not looking at treatment resistance. Half of your patients do not seek treatment. Out of those patients, and we know that depression is a global health burden. It's growing. 1 out of every 5, person is going to suffer from this chronic debilitating condition. 30% of your patients that you're treating are not getting any relief from your first line treatments. Out of that, there are half of those patients are resistant to first line treatments. When we say, patients are getting help, they are getting help with medications for the treatment of mood disorders. They're getting psychotherapy, combination of either one of those, and some advanced treatments like electroconvulsive therapy, transmagnetic stimulation, vagal nerve stimulation. There's a whole kind of array of new invasive techniques that are available, but 30 to 40% of patients are not responding to these treatments. So in some ways, we are looking for these kind of treatments, novel treatments. We also know the medications that are antidepressants that we have for treatment of depression, which is your first line, take weeks to work. You have already a patient who is struggling. You're giving them treatment saying, but it's not going to work for the next 4 to 5 weeks. And these are the patients who are at risk for hurting themselves as well, and they're not getting that relief. So when you hear about treatments that are being offered we are seeing in some way or form, again, definitely there is need for research and more information about these class of medications. But when you hear about that, these are giving some relief to some patients, then there is that excitement. Having said that, our first priority should be do no harm. So there is a need for medications or treatments that have a different mechanism of working, but at the same time come with a lot of how do we do it and how do we do it right. It's not generalizable. Not everybody is going to be a candidate for these treatments. How do we select? How do we use it in the right way? So the set and the setting. So trained professionals who are aware of what the side effects or adverse effects of these medications are, the environment it is being provided, how much of supervision are we giving, and how much monitoring are we doing. I think all these questions begs more information and more research. And so we need to weigh the risk versus benefits of these treatments. So even though there's a lot of enthusiasm about this, there are no silver bullets in medicine, especially in psychiatry. So I think we have to use it very carefully and use it very cautiously, and need more evidence-based data to support our use of these medications in variety of illnesses. As Andrew mentioned, they're looking at neurological disorders. In the field of psychiatry, we're looking at depression, anxiety, PTSD, addiction, eating disorders. So it's opening the door for other illnesses as well. And so, it has a little bit broader implications, not just in depression, but other conditions as well. So definitely, we need to be optimistic, but cautiously optimistic in use of these medications.
Thank you so much. Stacey, do you want to introduce your work and how you've been thinking about some of these ethical issues?
I would love to. Thank you so much for having me. It's wonderful to be here on this panel. I'm certainly looking forward to our discussions here, hopefully not too long after I get started with my background. My name is Dr. Stacey Armstrong. I am a senior researcher and the associate director of the Center for Psychedelic Drug Research and Education here at Ohio State University. Yes, like many, I think, who end up in this space, my journey here has been long and winding. I did not set out in the beginning to be a psychedelic-assisted therapy researcher, nor did I expect to be here, but I have since found myself in this space for lots of reasons. But, to give you a little bit of a background, I started my journey in Arizona. Which is a long, long way from here. That's where I attended undergrad, and I went to the University of Arizona. At that time, I was bound and determined to become a medical doctor. Reflecting now on that time of my life, I'm fond at that version of myself, reflect fondly on that version of myself, and also find it a little bit funny that as a teenager, we think we know exactly what we want to do. But undergrad was really helpful for me because it kind of opened doors to different majors, topics, questions that I hadn't considered before. And it was really helpful for me. And I fell in love with psychology, and I fell in love with family studies. So after I graduated undergrad, I pursued a PhD in clinical psychology, and I focused on children and adolescents, psychotherapies, research with kids, with teenagers. How do we provide treatments to these vulnerable populations in safe, ethical, supportive, and effective ways? early in my graduate education, I spent time specializing in the treatment of PTSD, first starting with children and adolescents. And I was particularly passionate about specializing clinically in this area because, specifically with children, because of the potential that exists for children if we can address and successfully treat their PTSD. Because we know that if childhood trauma is left untreated, it can lead to many devastating outcomes throughout adulthood. So early intervention is so important, and it can change the trajectory of lives. I spent time in this space. I was confronted with a lot of structural challenges to overcome in terms of how we provide treatments in our systems, particularly with kids and families who've experienced trauma. And those challenges and barriers to treatment are significant. And so I pivoted a bit, and I specialized after that in treating PTSD among civilians and veterans. So I switched more to an adult perspective. And after some time of providing this type of care to families, to veterans, to civilians, I really came to understand that our treatments are lacking. I began to recognize that the last significant medical advancement for a mental health concern was in the late 80s and 90s with the development of the SSRI. And even the SSRI isn't that helpful when it comes to treating PTSD. And so, as frustrated as I was with the lack of effective treatments that were available to me, I started to recognize how exponentially more devastating this was for the people that I was working with, right? Where time and time again, they were coming to therapy, we were working together, we had established these, goals together about what our treatment would be, and progress often was minimal. We did have successes and we celebrated them when we could, which is the beauty of the clinical work and what I take with me. But there were a lot of not successful interventions. And so I decided to take a break from clinical work, where I pursued a tenure track position, but I was called to research here at the CPDRE to help with a clinical trial that we were getting ready to launch, investigating the use of psilocybin for treatment-resistant PTSD among military veterans. I got inspired because I was excited about something that we could potentially have in our toolbox that could be helpful and help all of the clinicians and all of the patients who have been really struggling and who haven't had anything new or novel to help propel them to ease their suffering. So ever since I've started this, this line of research, I've been considering how these treatments might be beneficial for children and adolescents. So if we're talking about vulnerable populations, children and adolescents fall squarely in this space. Because I'm still very passionate about advancing treatment options for pediatric populations that forge the way for healthy adulthoods. And as such, I've spent quite a bit of time considering the complex pediatric medical ethics around this topic. This is not straightforward. This is not easy work. This is not easy to grapple with. But we need to start considering what it means for psychedelic-assisted therapies if we're applying these therapies to our most vulnerable. So specifically, things like what should we be considering to guide medical research for psychedelic-assisted therapy for children and adolescents? Unlike adults, we have to consider things like developing autonomy. That's not often something we consider when we're working with adults because we just assume, and they are granted with legal authority, autonomy. But they have parents involved, they have families involved, they have caregivers involved. And so in what ways are they involved in treatment? And what is the role of our healthcare providers, all of us ensuring that a child's best interests are at heart? So while that's kind of where I spent a lot of my time thinking, there are a number of other ethical considerations that I'm sure and we'll be getting into and diving into, but that's where my mind has been as of late.
Thank you, the three of you, for just sharing your thoughts. I mean, one thing that I think is really interesting that has come out of this conversation is the fact that for both you, Stacey, and Subhdeep, the research comes out of clinical, like, frustration and need, which I think is a really interesting doing a lot of these panels. Often the researchers are not the ones that have just sort of like had to sort of work with patients. So it is sort of an interesting, maybe it's, I don't know if that's like a feature of this kind of research, but it is sort of an interesting feature of the conversation. I mean, one thing that has become very clear is um, we've seen three different populations with different conditions, or four different populations that have been described, that the use of psychedelics might be a novel intervention. So it's clear that there's a possible wide population of people that might be interested in sort of seeing the effects of these kinds of interventions. And one thing that is clear is we need more research to really determine the actual effects of these interventions in a way that give patients informed options. And also, because we need more research, we need to do it ethically, right? And so one of the things that I was hoping that we could have a conversation about for the next 35 minutes or so is like really thinking about the ethics of the research of this kind of intervention. And you've brought up so many important ethical issues already. I'm just going to tap into some of those, and then we'll ask questions that have come already from the audience. So, I mean, just sort of a general question to get the ball rolling. You know, all clinical research has its risks. And so what, on your view, if anything, makes researching psychedelics different from other kinds of clinical interventions? Why don't we start with you, Stacey? You're not muted yet, and then we could go to Andrew or Subhdeep after that.
Sounds great. Happy to jump in here. Well, gosh, what makes this research different from other clinical research with other clinical interventions? I think one of the big things that comes up with this research, and one of the reasons that this research is so challenging, is because psychedelics are classified as a Schedule I substance federally, which makes it very difficult to obtain approval to be able to do this research. And that limits who can do it. There's a reason that these centers are at the universities that they're at, because the institutions can help support this research. They have the infrastructure there to be able to do this. They're able to take on the risk that's associated with doing novel research. But back when these substances were scheduled back in the 70s, when they were scheduled as Schedule I by the DEA, it really began the development of this idea that these substances are more harmful than the data suggests. And that ultimately created a stigma that these substances are dangerous and they will lead to serious adverse effects. So, while we're still in the very early stages of this research, we're also trying to overcome a very significant amount of stigma that exists that regulatory bodies are also swimming in. This is a cultural phenomenon. And so our regulatory bodies aren't immune to this. And so they're affected as well. Another thing that I think makes this research different is that as researchers assessing this, we're assessing two questions kind of at the same time, which is tricky. And typically we try not to do this, right? We want to just have like one question, make it as clear as possible, and assess it. But it's a package deal. We're looking at the substance and the molecule and how that's impacting outcomes, but therapy is also a huge aspect of this. Makes it very complex and makes it quite a bit different than many of the other types of clinical research, medicalized research that we do. And so this also poses issues for the FDA because the FDA is not in the business of approving things like therapy. That's left up to professional organizations, to state licensing boards. And so, they're kind of caught in this unique position of, are we approving the whole thing? Are we not? How do we even parse out, how much of improvement is because of the molecule versus the treatment itself? So I'll stop there, let other people chime in as well. But, those are some of the things that I think make this research quite different.
Andrew or Subhdeep? Why don't we go with Andrew and then Subhdeep? What makes this kind of research different, if anything?
So I've struggled with this question since I've started thinking about psychedelics back in 2019. The way that it's being regarded in the literature right now, there's an ongoing debate in the literature about this, is whether we should adopt psychedelic exceptionalism. That's what people refer to it as. So whether psychedelics themselves require an exceptional ethical and regulatory framework relative to all the other drugs that we develop, right? Like, is there something that's actually special about it? And then, there's the question, like, why are we having a panel about it right now? Why isn't just this a discussion about SSRIs, right? Why are they different, right? Is there a difference? And I've really struggled with that because it strikes me that when starting to write about these things, it's like, oh, we do have a framework for thinking about this already made, right? And we just apply it like, it's ready made. And we do have what seems different to me, and I think Professor Armstrong got onto this, is that there's, I won't say stigma, but I'll just say cultural mythos around psychedelics, right? And it cuts both ways. It cuts one way with regard to stigma, but also cuts the other way with regard to thinking as psychedelics as a cure-all for everything, right? And this is where like the bioethicist in me like starts to go, it's really wound tight about stuff. Is like, well, we'll think about applying it to this clinical population and this clinical population and this clinical population and this one. And it's sort of like, let's take baby steps first, as opposed to running. And I think that Dr. Virk, you had mentioned that in your comments too. So I think, again, it's when trying to struggle with this question, what's different about psychedelics? I don't know if there's something different about it. I don't know if we should hold, the jury's still out whether we should adopt psychedelic exceptionalism, but it does seem clear that psychedelics suffer from a kind of cultural mythos that cuts both ways. One way is regarding psychedelics as a cure-all for arguably desperate patients and families for incurable diseases, right? The other way it cuts is that we have a kind of stigma about psychedelic use, which could lead to bottlenecks, say in IRBs or at the regulatory level at the FDA.
Mm-hmm. Thank you.
Yeah, just to build on what both Andrew and Stacey, kind of mentioned, one is the stigma. How do you deal with that part? And as Andrew mentioned, the regulatory kind of like, hurdles that you have to deal with it. I've been doing phase 2 and phase 3 trials for over a decade now, 15 years. I've worked with newer medications with newer mechanism of action that have come into the market, approved by FDA for the treatment of depression, anxiety, even schizophrenia trials and bipolar. I can say from my experience that this warrants, there should be this field needs to know more about compounds like psychedelics because they are different. They are different than SSRIs and the psychotropic medications, even antipsychotics that have come into the market with the the side effect burden. So like clozapine has REMS requirement, which is a risk evaluation and mitigation strategy. Same thing with esketamine is part of the REMS program. I think this, in terms of one being Schedule 1, that right away limits its kind of use widely among researchers. So it's still not even in the clinical world, it's still in the research world. So regulatory challenges are going to be there. In the past, we have used medications alone. So when you look at your typical psychotropic medications, they have been researched independently. And then psychotherapies have been researched independently. Now we are combining both of them together. So we are looking at a medication for which psychotherapy is very critical and an integral part of its delivery. I don't think so we will be able to separate that, or we should not. But again, there are pros, like people have debated about that aspect as well. But right now, the way the research is going is it is going to be psilocybin assisted or psychedelic assisted treatment. It requires a lot of resources. We have, in all our studies, you're looking at extensive therapy, so preparation sessions, delivery sessions, post-dosing sessions, where you're utilizing trained professionals in a supervised setting. And so it requires a lot of these resources, and the sample sizes of the research are small. We don't have bigger trials. We are looking at, hopefully down the road, trials where we will be doing more of large sample size. So that kind of limits, also, that is a big limitation. Blinding of the, how can you be perfect at that? I mean, say there's no placebo, even for the trials that we are doing a low dose and a high dose. So I think that is also one of the, how do we functionally kind of make it possible to blind our readers, our therapists that are doing these studies. And then I think the bigger thing, which I can't emphasize enough, is how do we get good at assessments of adverse events, because some of these adverse events are overlapping with the treatment themselves. We know that psychedelics come with a huge, it's not only just physiological adverse events we are looking at sometimes challenging and difficult psychological adverse events. And so how do we separate that out, and how do we assess those serious adverse effects so that we are empowering the individuals to make informed decisions. So I think that is where the biggest struggle for me is doing the clinical trials, is that these are the biggest limitations.
Yeah, thank you. And those are there's so many interesting sort of things that I want to pick up on. I'm going to jump in and bring up a question that is heating up the Q&A amongst the participants. So one thing that Christine, Mark, and Tina have sort of been thinking about that seems different is this idea that we should whether or not we want the researchers themselves to have certain experiences with the intervention that is under investigation. And so, some of the participants were like, well, we don't expect this from oncology research. So what is it about psychedelic research that it seems like this would potentially be relevant? If you don't think it's relevant, then why do you not think it's relevant? So maybe I'll start with Andrew, because you brought it up in your presentation, and Stacey and Subhdeep, if you have any thoughts to just sort of think about this question. It's a super interesting one that the participants are talking about in the Q&A.
Yeah, so this was a serious matter debate at the Banbury Center workshop as well, where practitioners were on both sides of it, right? So why would we do it in the first place? Well, one obvious question or one obvious answer is that it would help with consent procedures. And so the individual who is taking consent would be able to describe what it is like to have such an experience. Another way in which would be helpful is that the person who is guiding the experience would be able to more acutely recognize adverse events as well and know how to get out of them because they have personal experience with it, right? But as the participants have already claimed, there is no requirement among oncologists to have cancer prior to becoming an oncologist, right? There is no requirement for orthopedic surgeons to have many fractures or a fracture before they fix a fracture, right? So it would seem strange that we would require practitioners to have this experience, except for the fact that psychedelics are intrinsically defined. The therapeutic benefit of it, in addition to the therapy, is intrinsically defined in terms of the subjective experience that you have, right? And so that seems to be really important, right? Where we came down on this at Banbury, however, is that the risk of adverse events in the practitioner when going through, say, licensure, right? If we were to require that person to have a psychedelic experience prior to being licensed as a psychedelic assisted therapist, that the risk of adverse events there are too great to require that individuals have a psychedelic experience. Maybe suggested, but to require it is too great. And there were many spirited, emotional stories from some of the participants at Banbury in which practitioners had adverse events, and then several days later took their own lives, right? It unearthed emotions and thoughts and trauma that they had not thought about before and put them at risk to actually go through this potential licensure process. So that's where we arrived in terms of our consensus statement. But I'm curious to hear other people's views.
I'm really glad to jump in. Yeah, happy to jump in on this conversation. I think there's a lot of really interesting conversation to be had here, and I appreciate, Andrew, kind of the value and the focus of, acknowledging that if clinicians were mandated to have their own personal psychedelic experience, that could impact state licensing. I mean, that has some serious potential complications attached to it. And so that's one big reason that that makes sense for, like, let's not make this a mandate. I think that there's also just kind of an understated acknowledgement of that we're somehow discounting the value of a clinician who is a psychedelic naive clinician. In all of this research that we're doing, we're always emphasizing diversity, right? We need diverse clinicians. We need diverse participants. And in one way that clinicians can be diverse is in their exposure to psychedelic substances. It is perhaps possible that a clinician who has had a psychedelic experience may minimize an adverse effect, that perhaps a psychedelic naive clinician may rise or elevate, to a level that maybe should be reported or should be acknowledged. And so I think there is, a perspective of a psychedelic naive clinician that is valuable in the clinical research. It provides diversity in terms of background, in terms of interpreting that I think we need in this space to be able to do this work comprehensively. I also think that one psychedelic experience is one psychedelic experience. Like, you've seen one. And so just because somebody has had their own psychedelic experience, we talk about it all the time in this space, these experiences are ineffable, right? It's hard to put it in words. And so if it's hard to put in words, it's going to be hard to describe to somebody to allow them to understand in a way that maybe we could, feel a different way about consent. But the thing is, someone's experience, if they've had one experience, is likely, just going to be their experience and may not be applicable to someone else. They might have a very different experience. So those are just a couple additional thoughts that I have regarding this topic. But I think there is merit to what somebody who has had a psychedelic experience can bring to the clinical room as well.
Subhdeep, do you want to add anything to this
question? We are almost out of time, but I'll just I think it's an interesting kind of proposal in a variety of ways, and it does warrant a further kind of in-depth discussion and something to ponder about. So yeah.
Great. Well, yeah, so in the interest of time, let's jump into some of the other questions. I want to get to the sort of stigma mythos question, and also the sort of scheduling structural question, as well as informed consent and vulnerable populations. So I mean, this is also sort of coming out of the Q&A from participants, from Anthony, who said this, but also from your own sort of presentations and thoughts. There is this mythos, there is this stigmatization, both potentially of the intervention, but also of the conditions that these interventions are sort of supposed to be treating. How should we think about these sorts of historical and political sort of factors as contributing to researching this responsibly? So I don't know. I mean, this is sort of a very broad question, but psychedelics research just has a lot of baggage, including past historical research, misconduct related to psychedelic research in particular. And so I'm just wondering to think, is there a way in which this colors your own thinking about how to design research, and how we should potentially regulate this kind of research? So maybe I'll start with Subhdeep, and then Stacey or Andrew, you could jump in afterwards.
Yeah, so I think for the purposes of informed consent, it's important to look at the patient population that we will be administering. So it is not just the the type of patients or which patients we are looking at or seeking for these research studies, but also the condition in terms of what they're struggling with. I think for purposes of research, for our studies, we do require that the patient is, giving full informed consent themselves. Now, for purposes of research in children and adolescents, of course, they require guardian or parents' consent, and same thing with somebody with cognitive impairment, that they would require a caregiver to be their consenting person. So it is the baggage that you mentioned about, after they enroll in the study and they're, under the effects of the medication, they are in a vulnerable state, or a highly what we call suggestible state. And there have been a lot of discussions about how do we mitigate that, and how do we make the environment safe, and how do we provide this under supervision of trained therapists and professionals who will guide through these patients through these experiences. So I think that is very important, is what type of patients are we getting into the studies, and who is providing these or monitoring these treatments while they're getting substances like that.
Mm-hmm. And Stacey, I know that you've been sort of working, maybe I'll sort of follow up both for Stacey and for Andrew. So Stacey, you've been working, you come from the space of thinking about adolescent research and sort of adolescent interventions. So that's a distinctive population. And Andrew, in the Q&A from participants, there have been questions about sort of um, uh, persons suffering with covert consciousness or disorders of consciousness. Are there distinctive ethical challenges that come with psychedelic research for that population? And also when it comes to dementia patients, like, how should we think about informed consent from when it comes to people who don't have who aren't determined to have decisional capacity or full decisional capacity. So maybe let's start with Stacey. How should we think about children? And Andrew, how should we think about other people with potentially decisional impairment?
Yeah, great. When it comes to children, and this was already brought up by Subhdeep, which is that when we're consenting minors, we're not really consenting minors, we're consenting minors' caregivers, legal guardians, often their parents, but sometimes other people, and we're assenting the minor. So there's kind of this kind of multi-layered consent process that we have to engage in. And as a trauma researcher, it does not past me that much of childhood trauma exists in the family, right? And so the families who are coming to seek treatment, how are we ensuring that we're enrolling safe families into these treatments and that we're not going to inadvertently expose somebody to a very vulnerable state, not only during the session, but in a period of time after as well, where they could experience harm. And so we need to be really thoughtful about what the screening process looks like for children. I say children, or perhaps children, but more in the forefront of our minds right now are adolescents. Making sure we're doing a thorough screening process, make sure we're screening the family as well. And we're making sure that as we're entering into this like safety and efficacy research space of, is this safe, is this effective? We're being really thoughtful about that process. The context is everything. I would argue the context is everything for adults, but because children, adolescents are this vulnerable population, we have to be even more thoughtful about what context are these potential research participants kind of showing up in this space with. And also, what is the role of the family in the intervention? And does that change based off of the age of the adolescent? And if it does, well, gosh, we have a lot of work that we need to do with these protocols because they are not designed for any kind of additional inclusion often of families. I think we have pieces that we could take from or we could lean on from certain types of protocols, but for the most part, they're very much focused on the participant themselves as being the target of the intervention and very little other support. So, those are some of the big things that we're thinking about in this space, particularly as it pertains to what this might look like with adolescents.
Okay, lots of thoughts swinging around. Let me hopefully I can say something that's somewhat intelligible. And I do want to address the consent issue and unique vulnerabilities of persons with disorders of consciousness and dementia. But I do want to just earmark some of the thoughts related to your original question, which is about sort of like the historical baggage of psychedelics. One thing that I really learned from working with my colleagues is that we can talk about historical baggage of psychedelics within Western medicine, but psychedelics originate from indigenous cultures, right? And the indigenous practices within those cultures. And interestingly, when thinking through the use of psychedelics in indigenous cultures, it's embedded within a completely different worldview. And what I mean by that is a relationship between the individual and the community, an individual with the natural environment, how we define dysfunction and disease, right? How we define medical interventions and so forth and so on. And it always strikes me as a bit of like we're trying to put a square peg through a round hole, like when we're trying to put psychedelic assisted psychotherapy into a Western medical framework. And it strikes me that a lot of the stigma and a lot of the cultural baggage, and perhaps even some of the criminalization of non-medical use comes from that mismatch, right? That sort of incommensurability between the way that it's used in indigenous cultures, right, where it's regarded as sacred medicines, right, and then the way in which we use it in we're currently studying it in an evidence-based framework in Western medicine. And it just strikes me that I just want to plant that seed because I think it's worth thinking about. Like when, for instance, we're trying to think of issues like informed consent, which is derivative from a Western medical framework. Right. So lots of stuff to say about informed consent, right? And I can earmark that for later, and we can talk about it. I'm really curious about the application of psychedelics in pediatric populations and informed consent there. I think want me to say like there's like so many different kinds of vulnerabilities that are different between folks with dementia and folks with disorders of consciousness. I think that the one thing that overlaps in terms of like a Venn diagram overlaps and additionally impacts the consent process is the feature of desperation in these patient populations, right? People who have dementia caused by Alzheimer's disease have a terminal diagnosis, right? And they're desperate for cures. People who have suffered catastrophic brain injury, their families in particular, are desperate to have them come back to wake up, right? And so they're in this situation where they're looking for cures. They're looking for interventions that are going to help them. And because of that desperation, it creates a unique environment for consent procedures to go awry, right? That people maybe are willing to risk a little bit more than they would otherwise not risk to potentially find a cure. And I'll let everybody in the panel sort of sort out whether psychedelics raises like serious concerns there. I would only say that folks with dementia and folks with that are struggling with disorders of consciousness, whether they're thinking about psychedelics or not, are thinking about involving themselves in research or looking for interventions through the lens of a kind of desperation. And I think that's important when we think about how we frame psychedelics as a research or clinical intervention for these patient populations.
So thank you. And I'll have to say that we only have a few more minutes, and this has been a very active Q&A from participants. So it's clearly something that people are passionate about and are thinking about in, I think, really interesting ways. So because this is sort of a moment for closing, I just want to invite each of you to just give us, in some ways we've learned a lot about, I think I am kind of convinced that there are some like real novel ethical concerns that really come up in this research, including the sort of vulnerability of the populations, the fact that the experience itself is a component of the research and is a component of the intervention and the potential benefit, but also that the actual research itself requires a much more incorporation of the clinician and the researcher through psychotherapy and through sort of thinking about the context. So there's all of these, it's so complex and interesting. So those are some takeaways from the conversation that I've sort of gotten. And so from each of you, what is one sort of important takeaway that you're hoping the audience will get from this conversation, an interesting ethical question or an interesting challenge that you think really is at the heart of what the ethics of researching psychedelics is? And so let's start with Andrew, and then Subhdeep, and then Stacey.
So we've been talking about bioethics and ethical issues, but I'm fascinated with psychedelics about what they reveal about the mysteries of human consciousness, and how consciousness functions, how consciousness can be altered, and then how consciousness intersects with the various clinical populations. The study of consciousness interacts with the various clinical populations that we've talked about today. And one thing that I really hope that people can look more at, think more about, and try to figure out is this business of ego dissolution, which we didn't talk about at all. I'm opening a can of worms right after. But I find that absolutely fascinating, and how the experience of ego dissolution could have like therapeutic value itself in the psychiatric world.
Thank you.
Yeah, and I think I'll just add to that too, is that psychedelic therapies and these medications that have novel way or novel mechanisms warrant rethinking of how mental health care delivery is provided, which includes medication and psychotherapy together. And so it is important to learn more about these treatments and how our brain is functioning. I think it just opens another way of approaching, and clinicians should be knowledgeable about substances like this. So be cautiously optimistic, even though there is a lot of unknowns with this treatment, but to be cautiously optimistic with these treatments and set expectations as well.
I love the term cautiously optimistic. I think that's a great way to describe where we are now. There's promise here. There's some data that signals something promising. And so, we must keep doing this research. I think it's important that we keep doing this research, but we need to do it safely. We have to do it ethically. And I think we can take some lessons learned. There are some very meaningful lessons in the history here, but there's also some other things that we can do as well in terms of, appropriation and acknowledgement where it is due. And in addition to that, I'm a clinician. So I'm a clinical researcher. I have, a lot of my investment is in the clinical aspects of what it is that we're doing. And, one of the biggest things that has come up recently, specifically with the MDMA FDA approval process, is this aspect of physical touch and how it's showing up during the therapeutic intervention on these dosing days. And we need to grapple with this, and we need to have discussions about it, because we need to establish some clear boundaries around it so that clinicians and our research participants are safe in these settings. And so, as kind of like opening another can of worms, something we didn't really talk about, that I think is one of the biggest, not the biggest, but one of the top things that we should be considering ethically in this research.
Thank you to the three of you, and thank you to the audience for your robust comments and conversation, as well as questions. We may try and post some of the questions and comments de-identified so that people have a sense of what was going on in the Q&A as well. And I appreciate the three of you really sharing your own perspectives on, and like sort of really sitting with the sort of nuance of this, of this exciting, but also, potentially just an exciting new space for research and clinical intervention in a lot of different places. All right. Thank you so much, everyone. See you later.
Thank you.